Hi there, I'm Dr. Kovalsky. I am a board-certified orthopedic surgeon who subspecializes in spine surgery. I am a fellowship-trained spine surgeon and have been in practice for greater than 30 years. Today we're here to talk about sacroiliac joint pain, often referred to as sacroiliac joint dysfunction. The sacroiliac joint is a joint between your pelvic bone and your lower part of your spine, which is called the sacrum. It, in essence, attaches your leg, which your hip joint is attached to the pelvic bone, and the spine is attached, the sacrum, to your torso. The sacroiliac joint is under tremendous amount of stress because every time we walk or move, body weight forces are transferred through the sacroiliac joint. Average patient cycles this over 2 million times a year. Complaints for people with SI joint pain, typically they're going to have pain in their buttocks, and the majority of the patients will actually point with one finger right to where the pain is, which is at the very top of the sacroiliac joint. About 40% of the patients will have buttocks and referred pain into their leg, which kind of mimics sciatica, and they can also have pain referred to their groin or hip joint. So prevalence of this is at least 25 to 30% of the patients that come to a practice like mine, where I specialize in spinal problems, will have sacroiliac joint dysfunction. Unfortunately, this is oftentimes misdiagnosed. There's three basic causes of why people have buttocks pain there. Number one would be a pain referral pattern from the lumbar spine due to nerve irritation. Second most common is sacroiliac joint dysfunction, and hip problems such as hip arthritis would be the third cause of pain. The problem with this diagnosis is there's no pathological anatomy that you can see on a CAT scan, MRI, or plain X-ray that tells you that patients have pain. The majority of the people over the age of 40 have mild degenerative changes of the joint, but that doesn't specifically tell us that they're having pain. The way we diagnose this, I call this a diagnostic algorithm. So the first part is just history from your patients. Surgeon has to be, or doctor has to be, suspicious that the sacroiliac joint could be a pain generator. We do a thorough lumbar examination to see if we can reproduce any neurological symptoms. We do provocative testing of the sacroiliac joint, actually try and create motion in all those 6 directions to see if that increases people's pain, and we also examine the hip joint. If we feel the patient clinically has sacroiliac joint dysfunction, the first recommendation is to have an MRI scan to see if they do in fact have neural compression. If the MRI scan is unremarkable, the next step is we do a diagnostic injection with steroids. This injection serves 2 purposes. We numb the joint up to see what the patient's pain response is. So they're asked to rate their pain 0 to 10 prior to the injection, and after the lidocaine, they're asked to rate their pain again 0 to 10. We like to see at least 50% improvement of their SI joint pain to consider this a positive injection. About 25% of the patients who have intra-articular steroid injections will get long-term benefits, as in months, and then those people are typically just treated with repeat steroid injections. Those who do not get better with the steroid injections have 4 to 6 weeks of physical therapy aimed specifically at the sacroiliac joint, and if that doesn't help them, we do a second lidocaine-only injection to rule out placebo effect. If the second injection gives them greater than 50% relief of their pain, then they're a candidate for surgery. So for many years, I haven't been doing surgery on the SI joint. In the 90s, I did some open sacroiliac fusions and found that to be a very traumatic operation with poor outcomes. So that surgery has been pretty much abandoned by the spine community. These are called iFuse implants. They're triangular shaped titanium metal, which is porous coated, same technology we use in total joint replacements. These implants are put in usually 3 or 4 perpendicular to the joint, and they actually prevent motion or stabilize it. So if you can see here, these implants are put through the pelvic bone into the sacrum, so part of the implant rests in both sides of the joint, and by putting it perpendicular to the long axis of the sacroiliac joint, they in essence block motion immediately. I personally have done over 300 of these with 90 to 95% patient satisfaction rate. If you think you have sacroiliac joint pain and you don't feel that it's been adequately diagnosed or treated, you're welcome to make an appointment to come to my office to be evaluated. You do not need a doctor referral, and we would be quite happy to evaluate you. Thank you.